be the first presenter, and be followed by Zaf. So I shall share my screen now. Can everyone see this? Can everyone see the slide?
Yes.
All right. Okay. Okay. For my case, this is based on the case write-up, previous case write-up that we have cheated because we are unable to clark the real case. So in this case, Shu, 6 years old, Malay girl, presented with complaint of rashes and pain over the right foot on the day of admission. So she was apparently well until on the day of admission at about 3 p.m. She has a sudden onset of pain at the dorsal part of the right foot, whereby she was unsure of the nature of the pain, but she claims it to be non-radiating with no relieving factor. The pain is exacerbated on walking, and she is unsure of the pain score. So the swelling, which was there was associated swelling with the right foot pain. However, the mother was unsure of the size of the swelling, but there is no any skin changes or any past discharge. She was unsure whether there's any history of recent insect bite, but the mother thought it was a sprain as the child had history of fall 3 hours prior to onset of pain. So in view of her condition, the mother brought her to Klinik Kesihatan Bukit Sekilau at about 6 p.m. on the day of admission, whereby she mentioned that the doctor noticed that there were multiple rash of pin size on the dorsal aspect of the right foot. It was purplish red in color. Otherwise, there is no similar presentation elsewhere. There is no any skin changes at any other part of the body. At about 8 p.m. on the day of admission, the parent noticed that the rash is worsened, whereby the rash extends to the distal mid-shin of the right foot. The size was between 5 cents coin size. The patient cannot walk due to the pain, and the pain became progressively worsened. So apart from the rash and the pain, there is history of fever 1 week prior to admission, whereby the fever was, there's no chills, it's low grade fever with no chills or rigor, no recurrent temperature. The mother claimed that it dissolved spontaneously upon syrup paracetamol. However, the mother was not sure which day it dissolved. Otherwise, there's no history of fogging in the neighborhood. There's no recent history of dengue in the neighborhood, and there's no history of jungle trekking. So otherwise, there's no any other histories, such as patient does not have no complaint of hematuria, no abdominal pain, no headache, no projectile vomiting or seizures, no bleeding tendencies such as epistaxis or gum bleeding. There's no bruises, there's no anemic symptom. Patient does not have any constitutional symptoms such as loss of weight or loss of appetite, no night sweats, no symptoms suggestive of SLE, such as rash over the face, mouth ulcer, or any hair loss. There's no chest pain, there's no shortness of breath, no URTI symptoms. On the day of admission, at day 2 of admission, there was the mother complained that the child had pain at the joint. The child developed the pain over the joint of the right knee. She was unsure of the characteristic. The pain was exacerbated by movement of the joint, and the child refused to move due to the pain. She was unsure whether the pain is migratory in nature or not. On the day 3 of admission, the rash, which was mentioned previously, the rash developed over the upper limb of the right elbow and the medial aspect of the right and the left thigh. So the rash become progressively worsened. So for the past medical history, this is her third admission to the ward. Her first admission was at 2 years of age due to the presence of right shin abscess, whereby incision and drainage was done. And on second admission, it was at 4 years of age due to history of shortness of breath, which was resolved with antibiotic treatment on admission. Apart from the incision and drainage done, there is no other past surgical history. Currently, the patient is not on any medication with no known drug allergy. So the patient was born term at 40 weeks via spontaneous vaginal delivery through induction of labor. But based on the case write-up, it was unsure why the mother had done induction of labor. The birth weight is at 3.5 kilogram normal. The mother had history of GDM on diet. She was admitted. The child was admitted to NICU for 1 day duration due to history of rapid breathing. She had neonatal jaundice for 1 week, which does not require any phototherapy. Regarding nutritional and growth history, she was exclusively breastfed until 6 months old of age, and starts to wean at 6 months onwards until 2 years. Currently, it's on adult diet of quarter to half plate of rice with chicken or fish or fruits. She is a picky eater and did not eat vegetables. Her growth is normal as claimed by the mother. She completed all her immunization based on the National Immunization Guideline. Developmental history, the developmental is up to her age with no developmental delay. She is able to walk and run well and can jump. She can use scissors well. She can write her own name, can draw human. She speaks well with multiple vocabs in full sentences. She can undress, socialize well with friends and in the kindergarten. She is the only child in the family with no non-medical illness. There's no non-family history of autoimmune disease or blood disorder. Patient live in Kampung Padang in a rent house, whereby the father is a businessman and the mother is a kindergarten teacher. The family income is about 3,500 per month. So in regards to the physical examination, the patient was on general examination, the patient was lying on the bed, conscious and alert, not in respiratory distress, appeared to be in pain. Hydration status was normal. There's a bannula attached at the right dorsal hand with no active infusion. On peripheral examination, hands were warm to touch. Capillary fill time was less than 2 seconds. There's no pallor, no jaundice. There was no central cyanosis or evidence of gum bleeding. There is no presence of gum hypertrophy, which could suggest leukemia. There's no palpable lymph nodes and there's no pedal edema in this case. The vital signs, there's no abnormality whereby patient is afebrile, the heart rate is not tachycardic, it's not and the respiratory rate is not tachypneic. Blood pressure is normotensive, where SpO2 is 100% under room air. So for the rheumatological examination, as patient presented with pain over the joints and the rashes. So on inspection, there's multiple rashes seen on bilateral limbs from feet to mid-shin and medial aspect of the bilateral thighs. There's petechiae and purpura, where there's purplish in color, raised and palpable lesion, well demarcated border. And the lesion is non-blanchable. But from that, there's a limited range of motion for the right knee joints with no local signs of inflammation such as swelling or redness on top of the joint. Other joints were normal.
Okay, based on this history and your finding at the moment, at this point of time, what would be the differential diagnosis?
At this moment, my provisional would be HSP because patient had 2 out of 4 criteria, whereby patient is less than 20 years of age, and she has purpura which is non-blanchable. But I have to see the investigation whether it is thrombocytopenic or not. Apart from that, my other differential will be SLE because patient presented with a history of.
The first differential will be Henoch-Schonlein Purpura.
Second would be acute rheumatic fever because patient had fever and
before that, what would be the better, professional. So you have Henoch-Schonlein Purpura. Another one will be
SLE because of the purpura and the joint pain.
other differential.
The differential, I would consider leukemia because patient have the fever and could have presented with the thrombocytopenia, which could suggest marrow failure.
What other purpuric condition that can be another differential?
I would consider also dengue, but I think this is less likely because patient have fever and joint pain, and then the purpura could be from the red of white island of white in the Red Sea.
Okay, all right, continue.
So inspection for the upper limb, there's on the right elbow, there's purplish in color, raised palpable, well demarcated, border, non-blanching, limited range of movement. Well, limited range of motion. Central nervous system examination, there's no abnormality found. The tone, power, reflex, and sensation are all normal on upper and lower limb. The cranial nerve examination is normal. On abdominal examination or inspection, the abdomen was flat, the umbilicus is centrally located and inverted. There's no surgical scar seen. On palpation, the abdomen was soft and not tender. There is no hepatomegaly. The kidneys were not palatable. So for the summary, my patient Shah, 6-year-old, Malay girl, presented with right foot pain associated with edema and multiple purpura over the thigh and upper limb on the day of admission. It is associated with arthralgia. There was no abdominal pain or hematuria. There's no bruising or anemic symptoms. There's no chest pain. Physical examination revealed a purpuric rash which was non-blanching, associated with limited range of movement over the right knee and right ankle joint. The abdomen was soft and non-tender. So in view of the finding, my provisional diagnosis will be HSP because patient presented with purpura and lesser than 20 years of age with presence of arthralgia. However, the points against will be there's no any GI symptoms, there's no any hematuria, which should be among the presentation of HSP. Apart from that, my differential diagnosis will be acute rheumatic fever because patient have fever, arthralgia, and purpura. However, there is no chest pain and there is no abnormality. This based on the Jones criteria. Leukemia is my under differential because patient presented with purpura, which could be an evidence of thrombocytopenia, but patient does not have any other evidence of marrow failure, such as anemic symptoms or recurrent infection. Patient does not also have loss of weight or loss of appetite. Patient the other differential will be SLE because patient have fever and purpura, but it does not fulfill the other criteria for the SLE, which would be presence of a discoid rash, the hair loss, the presence of the CNS depression and others. So the differential autoimmune thrombocytopenic purpura, also known as ITP, because patient have fever, purpura, but there's no thrombocytopenia, which have yet to be investigated. And lastly, it could be dengue because from patient have fever, arthralgia, purpura, but it's less likely because the fever was presented 1 week ago. So for the investigation, for the full blood count, there is normal platelet with no leukocytosis, no anemia. The renal profile result shows no abnormality. The coagulation profile, there's no abnormality seen, which is done to exclude if there's any clotting factor disorder. Urinary euphemia was done. There's no abnormality seen. CRP was not done in this patient. Serum IgA was not done in this patient, and stool occult blood was also not done in this patient. So these were the investigations done for this patient.
Okay, so actually, again, my question was if this is the way that you present in long, if this patient comes to you in long case, with the rashes not only confined to the lower limb, but involve the elbow joint as well. So your top two differential, even without the blood parameter, should be Henoch-Schonlein Purpura, and the second one should be ITP, right? That would be should be ITP, right? Because you are the one who described the rashes. Usually for Henoch-Schonlein Purpura, it confined to the lower limb, but you have patient who has rashes over the upper limb, right? So ITP would be the second differential. Now, how you differentiate? So if you have based on clinical examination, how you differentiate between Henoch-Schonlein Purpura as compared to ITP based on clinical examination alone?
Based on clinical examination,
Yeah.
I think the area of involvement whereby
Okay.
HSP usually involve the buttock area or the flexus area,
Okay.
whereby ITP is more generalized.
All right. What else about the rashes in HSP as compared to ITP? What is the current?
HSP is non-blanchable,
Okay. And of course tender lah in HSP.
and
Okay. So then next, usually the next question will be then how would you differentiate between ITP as compared to acute leukemia based on clinical examination?
ITP based on so based on clinical examination for ITP and acute leukemia.
Yeah, how
So
differentiation?
if it's acute leukemia, I would see signs suggestive of marrow failure. So I would like to see if the patient have anemia or
Okay.
patient is febrile, which could suggest leukocytosis and anemic. Whereby in ITP, patient usually is not jaundiced.
Okay.
And
Any other clinical findings would suggest a leukemia as compared to ITP?
leukemia could present with presence of splenomegaly and hepatosplenomegaly.
Okay, right. So organomegaly. Hepatosplenomegaly would be in acute leukemia, while ITP they don't have hepatosplenomegaly. They don't have splenomegaly. Okay, so that's how you differentiate. All right. So what is the principle of management in HSP?
So principal management in HSP is mainly supportive, supportive treatment, and then we want to treat for symptomatic because patient usually presented with pain. So in general, I would like to ask patient to have a bed rest and give adequate fluid resuscitation until the symptom resolve. However, if patient come also with complications such as GI symptoms, I will need to administer prednisolone to reduce the symptom.
What GI complication can occur in HSP?
It can present with intussusception, it can present with intussusception and susception
And pain, abdominal pain.
abdominal
Severe
pain.
abdominal pain would indicate report needs of corticosteroid. Quite straightforward. Okay. So I mean, this you shouldn't. This is actually a good case. I shouldn't forget on the presentation. Any question, dear friend? So usually in this situation, it's actually rash. So this is actually quite common to have this case in your lung case. So remember the differential if only rash, no systemic symptom. So ITP and Henoch-Schonlein Purpura. So if they have systemic symptoms, then always consider systemic condition like leukemia. So again, the question frequently in exam is how you differentiate between leukemia and ITP. Another question, how you differentiate HSP versus ITP. This is actually very common bonus question lah. I mean, ask you should. This is actually what they ask. Well, anything else? I think that's quite reasonable. Any question to the rest, guys? Question to your friends, or you want to ask any question?
Excuse me, I have a question.
Can I ask a question like in one of the criteria it says that we can use diagnostic biopsy to see evidence of IgA. Is that done like routinely or by post-mortem?
No, it's not done. It's not done routinely. And number one is actually it's a clinical clinical diagnosis, right? Henoch-Schonlein Purpura is clinical diagnosis. So primary, actually we do full blood count. Again, the reason has been discussed, inner profile, and actually urine FAM. You don't even have to do coagulation profile for patient because there's no bleeding tendency, and then some it's not ecchymosis. Okay, if ecchymosis, then probably you want to do coagulation profile, but it's actually just a petechiae. You want to look at platelet only, right? So okay, in ITP, if you do again, you need a full blood picture. This situation, what do you see in full blood picture if ITP? Any idea?
Megakaryocyte.
Megakaryocyte. Yes,
Megakaryocyte.
you see large platelet, right? You see large platelet. Okay. Other question?
Doctor, I have a question. In the Nelson textbook mention of IgG and also IVIG and also the plasmapheresis as part of the treatment. In our local setting, do we use such modalities for HSP?
No. I think if a complication occurred, you can have renal involvement in that situation probably, but when it's not a static treatment, usually conservative treatment, painkiller like what your friend has discussed, and if need rise and corticosteroid. That's all. I mean, unless you have a renal involvement, which is again rare, and then there's no use of. But I think ITP, yes, but not Henoch-Schonlein Purpura. Okay, ITP, yes, the either IVIG or IV methylprednisolone. That would be the treatment for ITP, but not for Henoch-Schonlein Purpura. So I think probably, is it you read about HSP? I think likely ITP, yes, IVIG and methylprednisolone, yes, but not HSP.
My second question would be, Doctor, for example, the HSP can present with like multiple system involvements. So in our when we state our diagnosis, do we need to specify like which system is involved? For example, like HSP with GI involvements or with renal involvements, to explain the symptom.
I mean, if in final exam you can you what you call this confident with your diagnosis, and it's okay. But I feel that this is a kind of answer that you should keep until the examiner asks you because during exam you probably don't have the leisure of having blood investigation, right? So you only have clinical examination and physical examination and a history. So I think try to be broad as possible in this situation that people examiner can ask you about HSP, ITP, and the differential. Right? But if it's you have the blood result and then you are certain, and then when you're working, example, you can say Henoch-Schonlein Purpura, there's no involvement of GI or what you call this renal involvement. I think it's okay. But for exam wise, I think just to be broad in this situation. That will be my suggestion.
Thank you, Doctor.
Okay. All right. Next. You got another one, right?
Yes. So I shall pass the floor to Zafirah.
Okay, Assalamualaikum warahmatullahi wabarakatuh to Dr. Salehin and my fellow friends. So, can you see my slide? Yes, sir. Okay, today I will present a case of first of all, this case is got from the case write-up as like Jazz. So if there is any lacking, I'm sorry. So this is a case of 1 year 4 months old Malay boy presented to emergency department of here.
Ada background
Nice. Kronos. Macam kejap, I think the internet is quite not okay. Kejap.
Buka ni.
Tutup dalam.
Cuba try buka earphone. Okay. So Doctor, I would like to ask, where is HSP common to be seen in the ward?
No, very common, very common, very common. So chances that you probably would have this case in long exam is a common, but usually HSP would be acute case to be from ward. It's not someone that we call up, because by the time they resolve, the ratio will be severe. So very common. ITP is common as well. ITP is common, HSP is common, right? In a way, you are lucky because our center is not oncology center. Otherwise, ALL, leukemia will be very common as well. So that ITP and what do you call this, HSP will be acute case from what? Very common.
Usually, we would expect the HSP to resolve. So Doctor.
Yes, majority will resolve. Especially like this situation, usually will resolve within a week. As compared to ITP, ITP may not come with, especially they can have, because ITP you can have chronic ITP. So when you clock the history, very important. If diagnosis has been made more than 6 months, actually is a chronic ITP, right? So chronic ITP can come as a chronic or acute, but for HSP is usually acute presentation. Okay, yeah, continue.
Yeah, sorry for the disturbance. Okay, so I will present a case of 1 year 4 months old Malay boy presented to emergency department of HTA with complaint of multiple episodes of bruises for the past 2 weeks. So she was apparently well until 2 weeks ago, 2 weeks prior to admission. The mother noticed there is single bruises on his forehead that was painless, measured around 1 cm by 1 cm. Which dark purplish in color, but not increasing in size and begin to disappear with time. And then 1 week later, the mother noticed another multiple bruises on the dorsal and volar aspect of 4 limbs, upper limbs and lower limbs. It was measured around 2 cm times 2 cm in a scattered distribution. The color of the bruises start from the black or bluish and then change to green over time and disappear. The parents did not see any medical attention because of that, because they thought that the child only had trauma, by accidentally fall or bump onto things. However, on the day of admission, the mother noticed there was another bruises on his abdomen, which is blackish in color, which around 3 times 3 centimeter. It was painless and not preceded by history of trauma. So the parents very concerned about these bruises and then seek for the medical attention. The bruises actually is associated with rashes. The rashes was pinpoint and reddish in color, with occurs during the 2 weeks duration. It started from the fossa of left ear release and then goes to the neck, chest, buttock, and thigh. It was scattered in distribution and the size is up to 5 millimeter only. However, the rash disappeared spontaneously with time as another bruises before. And the mother also claimed that it was also associated with poor oral intake 2 days prior to admission. Usually, he eats about 3 times adult diet meal per day and snacking 2 times. However, since 2 days prior to admission, he refused to eat. And then the formula milk feeding also reduced from 6 ounces to 4 ounces per feeding for 5 times per day. However, he's still able to tolerate the plain water. Upon further questionings, there is history of low-grade fever 3 weeks prior to the admission. It was not associated with childs and varicose, and the recorded temperature is between 37.8 to 38 degrees Celsius. The fever was relieved temporarily by rapid painting and syrup paracetamol. The mother brought the child to clinic, and the doctor then treated the child with as an upper respiratory tract infection. However, on this current admission, there is no fever reported. Otherwise, there is no history of epistaxis, gum bleeding, hematemesis, joint swelling, hematuria, or passing out bloody stool. He also did not complain of recurrent fever, lymphadenopathy, or constitutional symptoms such as significant weight loss. No malar rash or ulcer, hair loss, and joint pain. And then no sign symptom of anemia such as lethargy, pallor, and shortness of breath. The mother also didn't notice any yellowish discoloration or dark color urine or pale stool of the child. And then there is no similar presentation in his family, and no family history of bleeding disorder, liver disease, and cognitive tissue disorder. And the child was not on any anticoagulant therapy. For histostomy review, it was unremarkable. And then for past medical and surgical history, the child had no non-medical illness. This is the first episode of multiple bruises, and this is the first hospital admission. There is no history of surgical intervention done to the child before. And then for drug history, he was not on regular medication and not taking any supplement or any anticoagulant therapy. He had no non-drug allergy. For the birth history, antenatally it was uneventful, and then he was delivered at term via spontaneous cesarean with birth weight of 2.4 kilogram at HDAA. Postnatally, he was admitted for neonatal jaundice and underwent phototherapy for 4 days, but no history of prolonged neonatal jaundice. For nutritional history, basically he stopped the breastfeeding at 10 days old because of breast milk jaundice, and attend day weaning at 6 months old, and currently he had an adult diet, children first day, 3 times per day with snacking 2 times a day. And to compensate, to replace the milk, so he was on ongoing of formula goat milk because he had a corn and soy milk allergy, and then he still able to tolerate plain water. And then for the immunization history, he received the proper vaccination as well as scheduled by Ministry of Health up to 1 year old, which is MMR. And then next is developmental history. He attained the appropriate developmental milestone, which gross motor is he able to walk alone. And then for fine motor, he able to build tower 2 cubes. Speech, he obeys to sing. He able to obey to single commands and able to speak 4 to 5 words. And then for social, he able to drink from a cup. And then for family history, the parents claim that they are not a consanguineous marriage. The child is the youngest of the 5 siblings, and all of his siblings are healthy. And there was no family of malignancy, cognitive tissue disorder, and bleeding disorder. Then for social history, the child was living with a family in a single-story house at Bukit Istana, Kuantan. And then his father is actually works as a private sector worker, and his mother is currently full-time housewife. The household income is about 40,000 per month. And the neighbor clinic was primary health clinic IOM, which 5 minutes away from home. Then for physical examination was done on day 3 of admission. On general examination, he was conscious but fretful. He was sitting comfortably on the bed, active, reactive, and well-grown. There was no dysmorphic feature noticed, and there are 2 greenish bruises measuring 1 × 1 cm on his right forehead. He was not pale, jaundice, or sinus. His hydration status was good, and there was no malarash and alopecia noted. There was a granula at his left hand dorsum with no active infusion. On oral examination, his throat was not inflamed and tonsils was not enlarged. The oral hygiene was good and no bleeding tendency seen in the mouth. On the peripheral examination, his periphery were warm to touch with capillary refer tongue of less than 2 seconds. There were multiple greenish bruises varying in size, noted over his both arms, elbows, and legs. Petechian rash was noted on his left thigh and foot, measuring about less than 5 mm. There was no soft tissues or joint swelling noted and no lymphadenopathy. For vital signs, basically all are normal. And then for anthropometric measurements, also height is 76 and weight is 9.25 between 10 to 10 centimeters. And then for the systemic examination, the abdomen examination, there was a large blackish bruises measuring 3 × 3 centimeter noted on his abdomen. And otherwise, the abdomen was not distended, no scar noted. Then there was no hepatosplenomegaly and ballotobacchini noted.
All right. So as compared to the first case, so what is different about this child?
I think because this child came with bruises, with I think it's more to ecchymosis, while the previous case more to like rashes, petechiae, purpura,
Alright, okay. So, I mean, again,
the size.
even though the history, again, there's no systemic symptom, but this actually you have a generalized bruising as compared to, I mean, the first is like confined, mostly on the lower limb, right? They'll be classical. This one actually multiple bruises. So, based on this history, the differential will be?
My first differential, I would like to rule out first the non-accidental injury because the location of the bruises, and then I think after non-accidental injury, I would like to my differential next is idiopathic thrombocytopenic purpura because the acute onset and it was preceded by the viral infection. And
Alright.
usually the ITP is occur between 1 to 4 years old like that.
Okay. So, what investigation you want to do?
So the first thing I want to do is full blood count because it was to determine is this bleeding caused by thrombocytopenia or not. If
Okay, and then in this patient, because this is extensive bruising, and now there's actually a role of coagulation profile. What is another differential for boy? This boy, right?
Yes.
Yes, boy with the extensive bruising, 1 year other differential. If you don't have this result.
So apa tu? Hemophilia,
Yes, right.
because it was
Hemophilia.
insulin recessive.
Yes, but again, hemophilia, very important that actually you, the rashes, distribution of the bruising at the buttock, right? At the gluteal area, at the joint area where there's a strong history of trauma, preceding trauma, recurring, okay? They can happen, child is 1 year, even though classically we say we should diagnosis at less than 1 year. I've got a patient recently, it's already like 2.5 years. I came with extensive bruising of the gluteal area and happened to be a hemophilia. All right. So okay, then the differential diagnosis, that what which is listed lah. Okay. So go back into the result, the investigation. Okay, what else you need? You need a full blood picture. Okay. And then do you know what is a full blood picture? Giant platelet. Okay. So giant platelet. Okay. So the diagnosis would be
The acute idiopathic thrombocytopenic purpura.
all right. So yeah. So how do you manage this patient?
So this patient, basically for patient with ITP, it was most children remit spontaneously, and some of them actually had needs hospitalization. So I took this the management from the PITS protocol. So we consider the hospitalization in a severe life-threatening bleeding. Example of intracranial hemorrhage regardless of platelet count. And then if the platelet count is less than 20 with evidence of bleeding, so we need to consider for hospitalization. And if platelet count less than 20 without bleeding but inaccessible to the healthcare. And then last one is more to logistic issues. And then the choice of treatments actually include oral prednisolone and IVIG.
Okay. What did this patient receive?
This patient received IVIG. This is the progression of the child. First under the admission, no, on the second.
HTAA or UIA? Previously? Huh?
HTAA.
Okay, all right, okay.
So the child got the IVIG, and then the platelet increased from 6 to 47.
Okay, all right.
I would like to ask doctor, so this patient because the PITS protocol didn't mention about antibiotic. So why this patient had got the antibiotic oral erythromycin etazuccinate for cover mycoplasma?
Yeah, it's actually mycoplasma pneumonia can also cause one of the associated factor with causing not really ITP lah, actually cause hemolytic anemia. Okay, but again, difficult for me to comment. But probably, how many siblings the child has?
5.
5, and then some of them are school-going children, right?
Yes.
And then
because,
this is a pre-PKP ke masa PKP?
No, it's last year.
Okay, right. So again, if they have school-going siblings, these are usually one that normally can infect children with mycoplasma infection. It's difficult for me. They probably have taken some mycoplasma serology as well. So I think basically ES is try to cover mycoplasma infection. Right. Go to the previous slide. Previous slide, please. Before another. Okay. All right. Okay. Actually, even though the book say most children remit spontaneously, actually not really, because it will take a while. So for you, it's very important to be alert of ITP who comes again and again to hospital because of the relapse or because of the recurrence of the low platelet. Theoretically, if a platelet less than 50, there's of course a high risk of intracranial bleed of course they say incidents is not many, but I mean, I remember that when I was MO in HTA many years ago, we have patient with a chronic ITP, went to Kemaman Hospital with a platelet of under HTA but known to have ITP, platelet count of like 20. Patient has reduced conscious level, then admit to ward. Right, nobody monitor. So by the time patient comes 7-8 hours later, already unconscious. Right, came to us in HTA, patient already had intracranial bleed. So we never know. Okay, so any role of platelet diffusion for ITP?
I think no, because
No,
we
because
usually
this immune condition, you give platelet, will destroyed by the immune condition. Right. So choice of treatment, acute ITP. Another one is actually metaprep, another option. With immunoglobulin, yes, standard, and they may come back and with the platelet count still decreasing. So you remember that general treatment is either IVIG or corticosteroid. Okay. And then again, the question would be any role of platelet diffusion? The answer is no lah. Okay, and the patient can, yes, children can resolve, but some of them will develop into chronic ITP. Okay, and of course, yes, true, not all children with acute ITP neuralization, but if platelet count is less than 50, then I think you should give benefit of doubt and admit them and monitor them unless they live very near the hospital. Okay. All right. Okay. Quite straightforward. Any question? So I mean, you got two case like this. I mean, remember the differential. The second case, the differential should be ITP, should be infection, right? Should be leukemia, should be hemophilia. Okay, as compared to the first case. Okay, any question?
Doctor, I have a question about the differential diagnosis because this patient is a 1-year-old. Can we differentiate of vitamin K deficiency?
If the immunization status is quite clear, then less likely. But what you can do, you did your coagulation profile already, right? Then which will be prolonged? Vitamin K.
Vitamin K, both APTT and PT.
No lah.
Step 2 saja.
Satu sajalah. Vitamin K. Tak boleh dua-dua. Which one? PT lah, external pathway kan? Okay, the external pathway is PT will be affected. Okay, so the profile, your profile is normal. So unlucky, but in case of sepsis, example severe sepsis or coagulopathy, okay, there's a role of vitamin K because in this situation like sepsis, because of the consumption deficiency, you still need the vitamin K. So you can be guided by using the PT and APTT. Okay, all right. So APTT will be internal pathway. So there will be your you want to treat with FFP or specific factor. Okay, anything else? Any other question?
Doctor, for the first case.
Sorry?
For the first case, the patient is having fever and also non-blanchable rash. So should we consider also meningococcal infection?
If they are having fever, ill looking, yes, but this patient already had the fever resolved a week ago. Again, unlikely. But if they come acutely with fever and then come fresh, of course, pneumococcal pneumonia will be differential. Then you have to administer antibiotic immediately. Okay, but they are sick looking. Sick looking. So the hospital now still have no patient, HTA and UA, very little patient. You guys can go to ward already, right?
Next week.
Oh, not yet. Next week lah. But I feel the ward is still empty lah. Even my place, I don't have patient. 1 or 2 days. 1 or 2 only. Okay. Any other question? You usually on admission, by the time they were admitted, admission is mainly because of a painful rash. Fever is fever is not common during the acute when the fever develop. When the fever already developed, usually they don't have fever. So the fever is actually the preceding event, right? Just like ITP, the data show that may be associated with preceding infection in the viral, bacterial, preceding, but nobody know preceding is can be 1 week, 2 weeks, 1 month, right? So same like ITP, usually when they come in with acute condition, they don't have fever. They came in mainly because of the rash and bruising. So if they have concurrent fever at the time with the development of rash, then infection can exclude. Most important to exclude infection, sepsis, pneumococcal. First, if during presentation they have fever and rash, right? So you have to treat as infection first. But if there's no fever, the fever is preceding event 1 or 2 weeks, 3 weeks ago, then there will be something else, right? So for same HSP ITP, usually the fever is not during the episode of presentation. That will be a preceding event. I think in your patient as well, in the first case, the fever is not there when the patient was admitted, right? It's a week before. Okay. Any other question before we end? So this is again rash, bruising. All this actually you actually can start revising your the condition, and like hemophilia, leukemia, right? You already covered 2 diseases, right? Apart from studying this ITP, HSP, cover lah all these condition comes with bruising. And then again, what you need to revise is you need to revise the value of PT, APTT. What is a PT? What is APTT form? If you do, why do you need to do INR? No need INR one, unless patient is on warfarin kan. APT, APTT, INR tiga-tiga nak buat. Right? It's not doesn't come automatically. You don't take INR, they will not do INR. You shouldn't do INR for this condition because this patient is not on warfarin. Kan? Kalau nak on patient on warfarin, nak buat semua PT, PTN. Kita buat INR je lah. Why want to do PT, PTT, tiga sekali? All these tests come with cost lah. Right? So you must be very clear why you do this. So if you want to transfuse factor for hemophilia, you have to be very clear which one, A or B, which factor you transfuse. Kalau tak ada factor, which one, what you need to administer. So you cover terus lah since you are discussing this issue. Okay, take this opportunity. Okay. All right. So I think we can end up. Hopefully you have clear up your mind about this condition. Okay. All right. Okay. Assalamualaikum.
Salam. Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Okay.
Thank you, Doctor.